Acute kidney injury is a sudden deterioration of kidney function, and it's evidenced by either a rise in one of the blood tests called creatinine or decreased urine output.
By definition, has been present for less than 3 months. It results in the accumulation of uremic toxins and can not necessarily lead to fluid accumulation.
It's common, with an incidence ranging from 5% in all critical illness patients upwards. It is potentially lethal, and the mortality can range from 5% in single organ kidney failure to anything up to 80% in multiple organ failure requiring renal support. And it's a condition which is preventable in about a quarter of patients if risks are identified, if early management is put in place, and sometimes through quite simple measures such as adequate fluids, stopping nephrotoxic drugs, treating early infection and sources of sepsis. So it's a potentially preventable condition that could kill you and which occurs very frequently.
For a long time we thought that only severe acute kidney injury mattered and could kill people. But there's increasing evidence that even minor degrees of acute kidney injuries, degrees which we used to tolerate easily, are associated with an increased risk of dying.
In our audit from here, we have seen there's a threefold increase in the chance of dying if you have acute kidney injury compared to if you don't have acute kidney injury when you're in hospital.
We need to do things about it because it's associated with increased mortality, increased length of stay, and ultimately cost, and that's cost to the NHS, which obviously in the current financial climate is very important.
So the length of hospital stay goes up. We have seen a doubling of length of stay, but it's all over the world. We have seen when a patient has acute kidney injury, their length of stay is longer.
And certainly a recent study from the US showed that 25% of survivors of severe acute kidney injury describe their quality of life 6 months later as terrible.
We think that there are somewhere between 1,000 and 1,400 people each year who start renal replacement therapy on a long-term basis who would not be in that position were it not for acute kidney injury. And that's roughly a fifth to a quarter of all starters of long-term RRT in a year.
And we now know that people who only have a fairly minor rise in the serum creatinine have an increased risk of dying in hospital, an increased risk of getting infections, and an increased risk of subsequent chronic kidney disease.
The incidence of acute kidney injury is perhaps rising, and this is related to the case mix that we see in the hospitals nowadays. 50 years before, the mean age of the patients in hospital was much lower. So we have an older population with increased comorbidities, particularly cardiovascular, who are very prone to kidney damage.
We do more interventions, so angiograms, CT scans. There's going to be more acute kidney injury.
So there's significant short-term problem, i.e. mortality, but there are also quite significant long-term risks, not necessarily mortality, but other morbidity, in particular renal morbidities.
The NCPOD, which was named adding insult to injury, was a very, very interesting and informative exercise to improve AKI management in this country. It highlighted the fact that we do not manage these patients very well. Almost half the patients got care which is suboptimal, and this is not acceptable.
And these were failures at multiple levels. Failures related to poor attention to detail, failures in recognizing acute kidney injury on time, and failures in reacting appropriately and escalating care.
Making sure that we do these first steps in management of acute kidney injury well, which involves fluid resuscitation, management of sepsis, getting the seniors involved in the right time, and getting the transfers done which are necessary from a peripheral hospital to a central hospital well, we're likely to improve morbidity and mortality.
So there's a group of patients who have isolated kidney injury, acute kidney injury, which the nephrologists manage, but clearly there are a number of other patients who have multi-organ failure, so not just kidney injury. They may have respiratory problems, they may need to be ventilated, they may have cardiovascular problems, they may be on big doses of inotropes, and these sort of patients quite clearly need to be referred direct to critical care rather than to the nephrology ward.
The milder forms of AKI with, say, active urinary sediment in terms of having blood and protein need to be referred to a nephrologist, whereas the AKI with obstruction needs to be referred to a urologist, though obviously the degree of renal function needs to be looked at to see if they need renal replacement therapy beforehand. Looking at the more severe end of the spectrum, so AKI 3, these patients need to be referred straight away to either renal services or to the intensive care unit locally in order that patients can be stabilised and managed appropriately.
When patients first come in sort of acutely, the things we look for are what their potassium is. So if the potassium is high, they're hyperkalemic. It often means we need to dialyse them as an emergency. So they're very fluid overloaded as well, having a lot of difficulty with breathing, can't lie flat, having trouble talking because they're so short of breath. It's another sign we need to start dialysis quite quickly. On their blood figures, if they're very acidotic, it's another sign. And also if they're showing signs of uremia as well, they're feeling sick, they're headachy, it's another sign that we need to start dialysis quickly.
So what do they need? They need a coordinated approach by the individual doctors involved in care. They need a coordinated approach by a multidisciplinary team, which also includes the nursing staff and the pharmacists. And they need good communication by all these professionals who are involved.